All right, so I'd like to welcome everybody to Family Medicine Grand Rounds. Today is July 22nd, 2020. Just as a quick reminder, please register for attendance to claim not only credit, but also just attendance. The event code for today, or the event ID today, is 204047. You can do this from your cell phone, your smartphone, or computer. It's totally up to you. Dr. Scalabrin, can you advance it for me?
Oh, sorry, I'm having some. Here you go.
Awesome, there you go. I'd like to thank everyone for please muting your microphone once the presentation begins, just so that way we can manage the noise in the background. Of course, attending to the presenters, which we always tell them thank you for their time. Also being engaged in the session, we have been told that we will leave time at the end of the session to ask questions. Dr. Scalabrin has noted that you can either wait till the end because she will have time there, but if it's a burning question, of course, throw it in the chat or definitely ask. And then at the end, please complete evaluations. Evaluations are, of course, important for grand rounds, but also important for our presenters. So as mentioned, South Texas Regional Family Medicine Grand Rounds is in collaboration with our educational partner, which is the South Central AHEC. And CME can, of course, be obtained through our UTESCA CME office, as well as the next slide, I think, shares information about our AAFP collaboration. It's really important that we try to get as many people to register, so please try to do that. The one thing I will mention this morning is that we did have another episode of a different grand rounds being hacked this morning. So because of that, if we are forced to terminate grand rounds, we will end the meeting very quickly. And then our hope is that we will reestablish one by sending out emails to everybody that is affiliated with family and community medicine, and we have an approved email for. So just a little bit of preparation for that. Dr. Scalabrin has no relevant financial interest with commercial interest to disclose. And beyond that, we'll go ahead and pass it over to Dr. Scalabrin, who will be presenting Holding the Line. Thank you, Dr. Scalabrin.
Thank you. So first of all, I want to thank Dr. Nato and Dr. Wimmers for inviting me to present at Grand Rounds today. I also want to thank Dr. Sung, Dr. Cruz, and Nicole Rubio to help me coordinating the Grand Rounds. So the presentation that I'm going to do today is titled Holding the Line, How New York Healthcare Providers Fought U.S. First Wave of COVID-19. So my objectives are to discuss the importance of physician well-being during this pandemic, summarize clinical spectrum of COVID-19, discuss the importance of early goals of care conversations, and analyze COVID-19 management. So first, I would like just to clarify some terms. So COVID-19 stands for Novel Coronavirus Disease 2019, and that's the disease which is caused by SARS-CoV-2, which is the virus. So SARS-CoV-2 stands for Severe Acute Respiratory Syndrome Coronavirus 2. SARS-CoV-2 was discovered in December of 2019 in Wuhan, China. There have been some reports that suggest that the virus actually was first identified early November. But again, those are some suggestions. We don't have evidence. The origin is uncertain, but appears to have been a zoonotic infection that has adapted to humans. And that was based on genetic analysis where they saw a relation to bat SARS-like coronavirus. It was initially reported to the WHO on December 31st of 2019. And on January 30th of 2020, the WHO declared COVID-19 an outbreak, this outbreak a global health emergency. And on March 11 of 2020, it was declared a global pandemic. So let's look at this map. And this was last updated on July 9. And my source is from the Johns Hopkins University. And basically what we can look is that as per July 9 of 2020, we have had over 12 million cases around the world and over 558,000 deaths. And we can see that basically every single country has been affected. On this next slide, we can see the cases of COVID in the United States. Again, this was last updated around July 9, and we had over 3 million cases reported with more than 133,000 deaths. As you can see on the lower left graph, unfortunately, the number of cases continue to rise in our country. We can also see that the East Coast has been most affected. And I do want to bring up that if you guys remember, actually the first case was reported in Seattle. I think Seattle and California, just in general, the West Coast did a very early and strict lockdown. And as we can see today, they were able to contain a little bit better the virus than the East Coast. So let's look a little bit of what is important to you guys. So let's look at Texas. And what we can see here is that basically the number of cases kind of started to rise in April. And we don't need to look at these dot lines right now, but basically it's saying, you know, when everything was closed and then what happened when things are starting to opening. This is not really the point for this slide for me right now. What I wanted to just highlight is that by July 9, we had reported 8,201 new cases in that single day in the entire state. And at that time, we had it over 236,000 cases in the entire state. So it's clearly something that is still going on, and it's very important that we talk about it today. And I think to me, this is one of the most important slides, as what I think worries the most any health system is when we're gonna be overcrowded or when we're gonna run out of beds. So what we can see, it's comparing states, but we can really just look at Texas on the farther right side, which we can see that by July 8, we had about 9,000 patients that were requiring a hospital bed. So now I would like to share just a few words about my experience as a frontline provider in New York City, before we continue. So for those who don't know me, I'm a former family medicine resident from UT San Antonio, and I just completed my geriatrics fellowship at Mount Sinai in New York City. From laugh to tears, this year definitely made to history. I have been a frontline provider in the inpatient setting for COVID-19 patients since March. At the beginning, it was very scary. We had been following the news from Asia and Europe, but for some reason, it was still a surprise when we realized how bad the situation would become. When it arrived to us in March, we didn't know much about the course of the disease, treatment, and prognosis. Back then, we had only few case reports published about the disease. Early March, we had so many patients with a typical presentation that we didn't know we were being exposed until a few days later when the test came back positive. And during that time, a lot of my coworkers got sick. It was then that a new rule came in place: wear a mask at all times. As predicted, New York City had its peak in April, and residents, fellows, and attendings from multiple specialties were asked to work together as a team against COVID. The hospital expanded its capacity, creating multiple extra ICU beds and beds to assist with the high number of incoming patients. And for months, the entire hospital was one big COVID unit. We didn't know if we were going to run out of ventilators and for how long we would have to be triaging with very difficult conversations with patients and family members. Our patients were so lonely without the visit of their loved ones, but the technology was on our side, and a Zoom conference or a FaceTime was only a request away. With time, we created protocols that help us to provide extra guidance, which I'll be sharing with you today. One of my biggest fears was to get infected or to bring the virus home to my loved one. But we became masters on proper donning and doffing of PPE, and we felt protected. We share our experiences in a weekly basis with the psychologist and chaplain of the department to debrief, which was extremely helpful to realize that we were all together in this fight and supporting each other. Our fears and struggles were similar, and we had each other. I think this was the key to surviving the pandemic, to have protected time in our busy schedules to check on each other and share words of encouragement. During this presentation, I'll be sharing the protocols and management from Mount Sinai Hospital for COVID-19 patients. At any time, feel free to interrupt if you have any questions. I'll also save time at the end of the presentation. And I'll be sharing this presentation in case you prefer to not take notes. So let's start now with this graph about New York cases. This is a graph of cases, hospitalization, and death by age. So as you can see on the upper left side is the number of cases per age. And really what I want to highlight in this graph is that every single group age has been affected. This is not a disease that is only affecting the most vulnerable patients. Unfortunately, we have even had cases of severe disease in children. When we go to the next graph on the right side, it's the number of hospitalizations per age group. And then we can start seeing that, you know, the most number of patients are usually above age of 75, but we still have almost 1,000 patients that were aged between 45 and 64 years old. So pretty young patients. And then on the bottom, we have the graph about the number of deaths. And I think as expected, the most vulnerable patients are the geriatric population. So let's review a little bit about the clinical of the disease. So I have a couple of symptoms on this slide. If I could pick 4, I would say fevers, dry cough, fatigue, and loss of sense of smell and taste. On vitals, usually we have high fevers and hypoxia. I do want to highlight here that most of my geriatric patients did not present with fever, which that's also common on the geriatric population. They might have a pneumonia, they might have a UTI, and they usually do not have fevers. So do not expect those two to have a high suspicion for COVID. And what I think was very interesting is that even when patients were hypoxic, most of the times they didn't have the feeling of dyspnea. They were not complaining of feeling shortness of breath. Labs, again, if I can point a few of them, I have a list. I would say leukopenia, elevated transaminases, normal procal, and elevated CRP, ferritin, and D-dimer. On imaging, usually we're gonna get a chest x-ray or a chest CT, and it's a very typical multifocal or ground glass opacities, often in the mid to lower lobe. Now let's talk a little bit about goals of care. I think it's extremely important that we have discussed of goals of care early on. If possible, and as primary care physicians, we should even be having those conversations in the outpatient setting. Especially our continuity patients that we already have this relationship, we know them, they trust us. We need to have those conversations because patients tend to decompensate so rapid, and you don't want to have this conversation rushed. So if possible, talk to your patients, explore their wishes, what are their goals, and try to have that paperwork set even before they get sick. In general, if any patient that I would advise DNR, DNI in a situation outside COVID, I will make sure to actually have the conversation early on with those patients first. Extremely important to confirm next of kin or healthcare proxy as soon as possible. Patients, my geriatric patients, they were such in a high risk of delirium, and when they're delirious, they can't make their medical decisions, and then you are like in that situation that you need to make a next step and you don't know what to do. So you want to make sure that you have that paperwork, you know who you need to talk to. Most of my patients were in the hospital for a long time, and we not only had one family meeting, but multiple family meetings where you want to update what's going on, you know, explore what the patient knows what is happening. So few advices for family meetings. Know your patient, review the chart, know who that person is, what are their medical conditions. One thing that I thought that was very useful was to prognosticate. And there was a couple of tools that we used to use that was very helpful, especially if you're gonna make a recommendation to the patient or their family. So a couple of them, for example, is e-prognosis, Karnofsky, performance status, SOFA, functional status, maybe even like cognitive abilities. Just put together a lot of information and see where is your patient, and that will help in those meetings. Make sure to invite all relevant healthcare members, and if the patient cannot participate, if the patient wishes, make sure that the healthcare provider, the healthcare proxy or the surrogate decision maker is present as well. Thankfully at UHS, we have such a big group of specialties. So if needed, invite palliative care. If you need consultants that have been involved, whoever needs to be present, make sure that they are present. And always establish the goals for the meeting before starting. Because if not, sometimes you find yourself that, have been talking and there's a lot of emotions going on, and at the end it has passed 1 hour and we haven't got anywhere. So set what is the goal for your meeting before you walk into a meeting. So this is a pocket card that our department created, not only for us, but also we share with other specialties, because again, we were having so many family meetings during COVID times. So basically this is a 4 steps of how you want to do a meeting. So first of all, you want to invite. So make sure to open with requests for discussion with the patient or the healthcare proxy. You want to make sure that the patient is willing to talk to you and wants to talk to you that day. Also discuss what is the role of the communication, and that the plan is to prepare the future, to have a plan of care. After, and then on the bottom on the blue, I even typed like clear words that I would say to them. Next step is to explore. So you want to explore what they know about the disease, what are their values, and what are their goals. To me is always what matters the most. What matters the most to you? I need to know that, right? You can even explore a little bit about their culture, their family, because these all will be involved in the way they're thinking, or what are their wishes. Then make sure to prioritize. So you wanna determine their priorities for medical care. And at that time, you also want to summarize the conversation and inspect emotions, right? Those conversations are so difficult. People will really have different reactions. Some people will be really upset and will be upset to you, thinking that it's your fault. Others will be in denial. So expect emotions. And finally, you're going to plan. So you're going to, based on what your patient told you, what are their goals and wishes, you're going to make a plan. And a lot of times I would make a recommendation, but for that I need to ask permission if they want to hear what will be my recommendation. And basically at like very, overall, we can categorize patients in like these 3 different like code status, right? Some of them will say, I want to live as long as possible. It does not matter if I need to be in the hospital. It does not matter if I don't know who I am. It does not matter if I'm going to be connected to machines for a long time. Just do everything that you can. If I need ICU, if I need, IV medications, artificial nutrition, just do everything. Some other patients will express, I'm pretty happy how I am right now, and I would like to maintain this health. But if I can, then I don't want any treatment. If I can't get better, in quality of life, it's important to me. And then if the hospital is not making me feel better or worse, I want to stop treatment. And sometimes those patients will even say, do everything that you can, but I want a natural death. I don't want chest compressions. I don't want to be intubated. And other patients will wanted to have comfort care, and they'll say, I'm pretty happy, and the most important thing to me right now is that the few days or weeks or months that I have of life, I want to be comfortable, and quality of life is the most important thing. I don't want to go to the hospitals. I don't want to ever be connected to a machine. And I think those conversations, we can definitely have them with time with our patients in the outpatient. and we make sure that we explore and we respect, and even to guide them, right? If they get sick, they'll call you and they'll say, what do I do? And if we already have explored, we can help guide them what to do next. So this is just a quick reminder about the nurse statements. So again, you're gonna expect a lot of emotions during family meetings, and the nurse, it just helps us to kind of like how to respond. So always name the emotion. I can see that you were worried. Understand the emotion. This has to be the hardest thing you have ever gone through. Respect their experience. We have been so impressed with how you have been there to support your family. And then do also support statements, like our team will be there to support you through this difficult time. And always explore, right? If they're yelling or if they're in denial, just ask, like, can you tell me more about it? What worries you? And that will help you to kind of like go through the meetings. With that said, let's talk about management. But first, let's take a deep breath. There is little to no rigorous data on COVID-19 treatment. With that being said, I will discuss what Mount Sinai Health System suggestions for treatment for COVID-19 patients. So management is mostly supportive. So we want Tylenol for fevers and myalgias. You want to give supplemental oxygen to maintain oxygenation above 92 to 93%. You want to avoid fluids, even if triggering sepsis. You want to try to keep those patients on the drier side, as they are a very high risk of ARDS. It's okay to give small fluids if they are developing AKI. Always use IS, and even there is no RCT evidence for proning no intubated patients, we saw some improvement in our system. So let's talk about oxygen. So you need to check pulse ox daily in the room and titrate as needed. If it's too low, meaning less than 92%, always titrate up immediately, real time. Those patients tend to decompensate very rapid. If they're saturating well, you can down titrate, do it in real time, just watch for 5 minutes. And always update your team and the nurses if you do any changes with the oxygen. You want to make sure that everyone involved in the patient's care is aware of what's going on. So a quick reminder, you're going to start with nasal cannula. You can titrate up to 6 liters. If it's less than 92% on 6 liters, you can escalate to non-rebreather. And the max amount is 15 liters. If they continue to desat on 15 liters non-rebreather, then if it's consistent with goals of care, that's when you're gonna consider intubation. But if you have a negative pressure room available, you can definitely consider high flow nasal cannula or non-invasive positive pressure ventilation. Or your patients are DNR, DNI. I mean, they wanna be comfortable. If at the time they might need high flow and they're okay with that, just give them high flow. So proning has been well described in the care of mechanically ventilated patients with IRDS. And early reports from China describe some clinical benefit with COVID-19 patients with proning. So you might want to consider in patients who are hypoxemic, who are requiring no invasive supplemental oxygen, and who are alert and oriented. So here is an image of what proning means. So it's going to be between 30 minutes to 2 hours, and you're going to ask the patient, you're going to teach the patient how to self-position and change positions every 30 minutes to 2 hours. So first, they're lying on their belly. Then you ask them to switch to the right side. Then they are sitting up. Then they're lying to the left side, and then go back to lying on your belly. With that said, our protocol had some inclusion and exclusion criteria. So inclusion, it was all patients, non-ICU units with primary diagnosis of COVID-19 infection. They have to be alert-oriented ×3, able to follow commands into self-position. If they are requiring any escalating oxygen requirements, so meaning more than 6 liters of nasal cannula, non-rebreather, high flow, or non-invasive ventilation. Exclusion criteria, so if your patient has hemoptysis, if patient is on enteral fits, patient has any nausea, vomiting, if patient is not able to, has any movement restriction or immobility or third trimester pregnancy, any open chest wall, or unstable hypotension, unstable arrhythmias, any recent procedures, facial trauma or surgery, or unstable spine, femoral, pelvic fracture. I do want to mention here that I had so many patients that came into the hospital, emergency room, chief complaint, I had a fall, x-ray shows a pelvic fracture, and they were COVID-19. And then when you get the full history, you realize that they have had symptoms, very, atypical symptoms. They didn't have fever, they didn't have a cough, they were just feeling fatigue and tired and loss of appetite. And that probably caused the fall. And then the reason really why they come into the hospital was the pelvic fracture. And then when you check their pulse ox, they're like 88. So I had a lot of patients like that, which was very surprising at the beginning. Remember that patients with COVID-19 may be unable to tolerate PO due to prolonged periods of non-invasive positive pressure ventilation, delirium, or just the critical illness. So you want to consider other forms of nutrition like enteral feeds or parenteral nutrition, just like in other critical illness. So usually you're going to consider at 7 to 14 days. So now let's talk about pharmacology. So I'm going to discuss hydroxychloroquine, when to give antibiotics for CAP or HAP, when to use steroids, anticoagulation, and I'm also going to talk about some of the clinical trials that are going on, which includes ritonavir, convalescent plasma, and monoclonal antibody. So let's start with hydroxychloroquine. So this first study, titled Observational Study of Hydroxychloroquine in Hospitalized Patients with COVID-19, was published in JAMA on June 18. Remembering that hydroxychloroquine has both anti-inflammatory and antiviral effects, its use for COVID-19 patients came from small studies that had either been uncontrolled or underpowered to detect meaningful clinical effects. Despite that, on March 30 of 2020, the FDA allowed its use in hospitalized patients with COVID-19 who were not in clinical trial. So the objective of this research was to study the association between hydroxychloroquine use and intubation or death. And this study was done in a large medical center in New York City. And so the data was obtained from consecutive patients hospitalized with COVID-19. They excluded those who were intubated, died, or were discharged in the first 24 hours after presentation to the emergency room. So hydroxychloroquine was given to COVID-19 patients who had moderate to severe disease, which was defined as a resting oxygen saturation of less than 94% on room air. This study recruited 1,376 patients with a median follow-up of 22 days. The majority of patients were aged between 60 to 79. They were Hispanic and overweight. The most common comorbidity was hypertension followed by diabetes. And what they found is that 58.9% of those patients who received, so from the 1,376 patients, 811 or almost 60% received hydroxychloroquine. The medication was given even on the first 24 hours, but if not in the first 48 hours of presentation to the emergency room. And what they found is that about 25% of those patients had a primary endpoint event, which means intubation or death. And what they really concluded is that the risk of intubation or death was not significantly higher or lower among those patients who received hydroxychloroquine, with a hazard ratio of like 1.04. So, and at that time, they're like, we need more randomized controlled trials in patients to continue to study hydroxychloroquine. I did want to bring up this study because I think that was one of the medications that we have most heard in the media and what people have most talked about it. So no, it didn't improve outcome. Next study, I thought this was extremely interesting, especially as primary care physicians. I can see, patients calling us, should I take hydroxychloroquine if I had someone in my family was tested positive and I have been in contact? So I found this study, which is called a randomized trial of hydroxychloroquine as post-exposure prophylaxis for COVID-19. It was published in JAMA on June 3rd. And so as the title says, it was randomized, double-blind, placebo-controlled trial across US and some parts of Canada, testing hydroxychloroquine as a post-exposure prophylaxis. So all participants were adults who had a household or occupational exposure to someone with confirmed COVID-19 at a distance of less than 6 feet for more than 10 minutes, while they were wearing either a face mask or eye shield, and that was called high-risk exposure, or if they were wearing a face mask but they didn't have an eye shield, and that was called moderate risk exposure. So within 4 days after exposures, the patients were randomly assigned to either receive placebo or hydroxychloroquine. The primary outcome was the incidence of either laboratory confirmed COVID-19 or illness compatible with COVID-19 within 14 days. The median age of those patients or participants were 40 years old, and 66.4% were healthcare providers or workers. About 30% had chronic health conditions, being hypertension the most common, followed by asthma. So overall, what they saw is that new COVID-19 developed in 107 of the 821 participants. So that was about 13% during 14 days follow-up. The incidence of new illness did not differ significantly between those receiving hydroxychloroquine and those receiving placebo. And what they found is that this difference equates to a number needed to treat to prevent one infection of 42%. So basically their conclusion is, in this trial, high dose of hydroxychloroquine did not prevent illness compatible with COVID-19 when initiated 4 days after high or moderate risk exposure. So bottom line, no hydroxychloroquine. Now, when to use antibiotics to cover for community-acquired or hospital-acquired pneumonia? So you want to consider to those patients who are acting like a bacterial infection, if they have leukocytosis, if they have elevated procal or a very dense opacity on chest x-ray, or if at any point your patient has a clinical decompensation, just recheck procal, repeat chest x-ray, you might want to start antibiotics. Steroids. So there's really insufficient data to provide recommendations for of steroids in COVID-19 patients. Some patients may benefit from therapy. The WHO and the CDC guidelines had stated that steroids should not be given in a routine basis to COVID-19 patients, especially in the initial phase of the illness, meaning the first 7 days. We think that steroids might have a role maybe later in the course of illness when patients becomes very sick with severe pneumonia or ARDS. So Mount Sinai recommendations for steroids were COVID-19 confirmed, less than 7 days since the onset of ARDS, suggestion of a cytokine release syndrome-like picture when they have very elevated CRP or high ferritin, or those patients that are requiring high levels of oxygen, meaning if they are intubated with a PEEP above 5, if they are on high flow, BPAP, or non-rebreather. So you can consider steroids on those patients. What we used was methylprednisolone, 1 milligram per kilo per day, divided every 12 hours for 5 days, and then you have to taper over the next 5 days. So anticoagulation. I think at this point, we know that COVID-19 is not only a respiratory disease, but also a disease of blood vessels. The first study that I have here, I think was very interesting. It was published in JAMA on May 21st, and it compared 7 lungs obtained during autopsy from patients who died from COVID-19, compared with another 7 lungs for patients who died from ARDS due to influenza A H1N1. And they also compare with 10 age-matched uninfected control lungs. And what they found is that those patients who die due to COVID or influenza, they have this severe endothelial injury, which is associated with the presence of intracellular virus and disrupted cell membranes. A T cell infiltration. The difference that they saw on COVID-19, it was this distinctive vascular feature, which we have the virus in the cells causing disruption of the membrane, as well as widespread thrombosis and microangiopathy. So what they also find in this study, which I thought was very interesting, is that the alveolar capillary microthrombin was 9 times as prevalent in patients with COVID when compared with influenza. And the amount of new vessels was 2.7 times higher than those with influenza. So in this small series, they show all these angiogenesis that is very distinguished from patients with COVID-19. This next study was actually done on Mount Sinai, and it was pretty shocking. It is a report of 5 cases of large vessel stroke in patients younger than 50 years of age. They presented to Mount Sinai Health System, New York City, with diagnosis of COVID-19. So those 5 patients, you can see that 4 of them were male. 2 of them had no past medical condition. 1 had undiagnosed diabetes. 1 had hyperlipidemia and hypertension, and 1 did had a previous history of mild stroke and diabetes. 2 of them presented with no COVID symptoms at all. 1 of them just reported lethargy, another 1 reported fever, cough, and lethargy, and 1 reported cough, chills, and headache. The outcome, thankfully, 1 was discharged home, 2 were discharged to rehab facilities, and at the time this was published, we still had 1 patient in ICU and 1 patient on the stroke unit. So with that said, knowing how this blood vessel disease that COVID causes, Sinai came up with a anticoagulation algorithm, which the bottom line is you want to anticoagulate all your patients. The question is, are you going to do therapeutic or are you going to do prophylaxis? So if the patient is in ICU, you're going to do heparin IV treatment. That's a therapeutic, 100%. Patients that are on the regular floor, it will be based on kind of like your evaluation on how patients are doing, how are their OT requirements, how high are the D-dimers, how high are like other inflammatory markers like CRP. So if they are not considered a high risk, you can use apixaban or you can use Lovenox once a day. If you think they're a high risk, very high OT requirements, high D-dimers, high CRP, then you might consider doing a therapeutic. Again, this was not black and white. It was very kind of provider dependent, depending on your patient. You definitely want to consider if your patient is geriatric with a lower creatinine clearance, you want to dose apixaban instead of 5 milligrams BID, 2.5. If they have renal failure, you might want to avoid Lovenox. You need to do heparin. You always want to, weight balance, what are the risks of bleeding. And all those patients who were on a therapeutic anticoagulation, they were discharged on apixaban for 2 weeks, okay? And as an outpatient provider, it was very important that I found that a lot of patients were discharged. For some reason, the medication was not dosed to be only for those 2 weeks. And then you're seeing them on the follow-up for hospital discharge, and it's week 3, and they're still being anticoagulated. So you want to make sure that if you're going to discharge them on anticoagulation, there's a stop date, right? This is not lifelong anticoagulation. Now let's talk about some of the clinical trials. I'm just going to spend a little bit more time on Remdesivir because I think this is the one that has made more the news. So let's talk about remdesivir. So the first study that I have is was titled "Compassionate Use of Remdesivir for Patients with Severe COVID-19," and that was published on JAMA on April 10th. So remembering that remdesivir inhibits the viral RNA polymerase, which has shown in vitro activity against SARS-CoV-2. So in this study, remdesivir was given on a compassionate use to patients hospitalized with COVID-19 who had an oxygen saturation of 94% or less or room air, or who were already receiving oxygen support. In addition, they had to have a creatinine clearance above 30, serum levels of AST and LLT no more than 5 times the upper limit, and they had to agree to not be under another clinical trial. So patients received 10-day course of remdesivir. And on this study, we had 53 patients, which data was analyzed. And at baseline, from those patients, 30 patients were on mechanical ventilation and 4 patients were on ECMO. They were followed for 18 days, and they saw that 36 patients, about 68% of those patients, had an improvement in oxygen support, including 17 of the 30 that they were intubated were extubated. A total of 47% of patients were discharged, and 7 patients, or 13% of the total, died. They did see that the mortality was higher among those patients who were receiving invasive ventilation. In those patients who died, the median interval between remdesivir and death was about 15 days. So I think this study, it was, one thing that they didn't do was to collect viral load data to confirm like any antiviral effect of remdesivir or any association between viral load and viral suppression. But they saw that, more studies needs to be ongoing, randomized placebo-controlled trials to see, again, they did see about 68% improvement. So after that, we have another study, which by the time it has been published, we're still on preliminary report, but it's called remdesivir for treatment of COVID-19. And that was published on May 22nd. So this was a double-blind, randomized, placebo-controlled trial of IV remdesivir in adults hospitalized with COVID-19 with evidence of lower respiratory tract involvement. This study was on 60 trial sites, including the US, Denmark, UK, Greece, Germany, Korea, Mexico, Japan, and Singapore. Patients were randomly assigned on a 1-to-1 to even receive remdesivir or placebo. And the primary outcome was the time to recover from the disease. And that was set as patient being discharged or hospitalization only for infection control purposes. And what they found is that, so we had a total of 1,063 patients, about 538, sorry, there's a mistake on my slide. So it was about 538 assigned to remdesivir and 521 to placebo. The mean age was 58. 64 of those patients were male, and about 50% had at least 2 or more comorbidities, being hypertension, obesity, and diabetes the most common. And most of those patients, about 88%, had what they call severe disease at enrollment. So the preliminary results indicated that those who received remdesivir had a median recovery time of 11 days comparing to 15 days in those who received placebo. The Kaplan-Meier estimates a mortality of 7% with remdesivir and 11% with placebo. So the conclusion of this study is that the preliminary results support the use of remdesivir for patients who are hospitalized with COVID-19 and require oxygen therapy. I think that's very important to point out, especially if we get calls, can I get remdesivir, right? So those studies are hospitalized, requiring oxygen. They do highlight the need to identify COVID-19 cases and start antiviral treatment before the pulmonary disease progressed to mechanical ventilation. However, they did see a high mortality despite the use of remdesivir. So what they stated is that it's clear that treatment with an antiviral drug alone is not likely to be sufficient. And future strategies should evaluate antiviral agents in combination with other therapeutic approaches or combination of antiviral agents to improve outcome of COVID-19 patients. Now, really quick, I'm going to talk about convalescent plasma. So this study, 5 very sick patients were treated with convalescent plasma, and all patients had confirmed SARS-CoV-2 infection. They were treated with 2 transfusions, and donors, they had to recover from the infection. They tested negative for current infection or other respiratory virus before donating the plasma, and they were asymptomatic for at least 10 days. And what they found is that the viral load of the patients who received plasma transfusion improved 1 day after transfusion, and all 5 patients had undetectable viral loads after 12 days. They also saw that ARDS resolved in 4 patients at 12 days after transfusion, and 3 patients were weaned from mechanical ventilation with 2 weeks of treatment. Of those 5 patients, 3 have been discharged from the hospital. They had all very long length of stay, 53, 51, and 55 days. And at that time, 2 were in stable conditions at 37 days after transfusion. So very quickly, I'm just gonna talk about monoclonal antibody, tocilizumab. Very challenging to say that drug. Tocilizumab is a monoclonal antibody that binds to interleukin-6 receptor with high affinity, and it prevents immune damage to target cells, alleviating the inflammatory response. So this was a retrospective study that observed the treatment with 21 patients who had very severe and critical COVID-19. What they show is that symptoms, hypoxia, and CT opacity were improved after treatment in most of the patients. I would say we have very, very few really studies or results about monoclonal. I do know that a lot of centers throughout the country are doing clinical trials. So I just want to bring that up. I'm not going to spend too much time. Again, I'll be sharing my presentation. This is the Mount Sinai Health System Treatment Guidelines, and that's what they were doing. Just remember, the most important thing is really supportive care, and just, you know, whatever your institution is offering, whatever clinical trials they're doing, advocate for your patients, see if they can, you know, qualify, and see if there's anything that, you know, you can offer it to them. But I would say number 1 thing, supportive care, just be on top of their oxygen, be on top of what are their goals of care, and anticoagulate your patients. So data to trend, I would say daily, you want a CBC, a CMP, you want to look at liver function test, CRP, ferritin, and LDH. I don't really have a number to say what does ferritin means, like how high is high, or why am I really looking? I think what help us is if the patient is decompensating, if I see there are like inflammatory markers are going up, ferritin, D-dimer, maybe that's when I make the decision to, instead of like do a prophylaxis anticoagulation, I would do therapeutic doses and see if they will have any improvement, especially to try to avoid any complications. Usually you're gonna check on admission at least once a pro-colon chest x-ray, but remember, if they decompensate at any time, just recheck. In our hospital, on admission, we are also checking troponin, lipid panel, cytokine profile, and that was really based on a lot of the clinical trials. So we had all these labs, which was part of just studies that we were doing on admission. I think, you know, each institution will have maybe particular things. I would say what you want to check daily, it's the top part of my slide. Some few considerations. So there was a lot of back and forth regarding ACE inhibitors and ARBs. Are they contraindicated? Are they protective? Should we start patients? So ACE inhibitors and ARBs, they're fine to give. But if they have been on those medications before, that's their home medications. Do not start any patient on an ACE inhibitor just because they have COVID. Avoid nebulizers, use MDIs instead, and work as a team. So minimize nurse exposure. So if you can use Lovenox, which is once a day instead of heparin, use Lovenox. Cluster all timing of the medications. If the blood glucose is a go, you can stop doing acute checks or insulin sliding scale and just monitor with daily BMP. Also, you can consider one time or a dose of IV Lasix if the patient is maxed out on O2 needs. And I'll say at that time, if you're like hitting the wall, just ask for help. UHS also has a lot of consultants, reach out to ID, Palm, whatever you need help with if you feel you're struggling with your patient. So remember, all patients will have contact and droplet precautions. This are the guidelines for the PPE from the CDC. I'm not gonna spend too much time on it. What I particularly did is I had an N95 covered by a surgical mask at all times that I was in the hospital. If you're seeing patients and if your hospital allows that, if you're seeing patients back to back on the rooms, you can use the same PPE. But that also depends if you can leave a room with your gown and enter to the next room. It really depends if it's all like a COVID unit or not. And your face shield, every time you take it out, you want to make sure that you're wiping it with a Clorox because you can definitely reuse that. Another thing that was very useful, we used to do, especially early at the beginning, we used to do rounds, at least 2 physicians together, and we'll make sure that we're checking each other, that we're all gotten up and everything was looking fine before we entered the room. Make sure to maybe have like patient's phone number in case you want to ask something and you forgot as soon as you left and you already removed all PPE. Whatever works for you. So when to discharge, so it's okay to discharge with fevers. And use the labs to help support your decision making. The goal is that the patients go home with room air pulse ox above 92%, unless you have decided to pursue home oxygen. Usually, I wouldn't really send any of my patients with more than 3 liters O2. And you want to ensure home quarantine plan and understanding. So I will highly recommend that you have detailed instructions in the DC paperwork. And you want to tell them patients must self-quarantine at home, and 3 of the following have happened. No fever for 72 hours without the use of antipyretics. Respiratory symptoms are improving. And at least 7 days have passed since symptom onset, which usually I would say is the day that you felt the most sick. So usually it was the day that they came to the emergency room. And last, I just wanted to talk a little bit about antibody testing, especially as primary care physicians. I think we're gonna start having a lot of questions about, I wanna get antibody testing, should I have antibody testing? So things that I think it's extremely important to tell the patients. One, it's unknown how long IgG antibodies to SARS-CoV-2 will remain present in the body after infection, and if they will confer immunity to infection. Unfortunately, I was reading a recent article that was saying that about 20% of the patients who had symptoms and antibodies, they were losing antibodies on their follow-up. So 2 months later, they even had no antibodies or the antibodies were dropping. And about 40% of patients were asymptomatic but found to have antibodies also had their titers downtrending. So we don't really know what it means exactly right now. Remember that a positive test means that antibodies to SARS-CoV-2 were detected. Negative test, it was not detected in the specimen above the limit of detection from the lab. Really, the absolute sensitivity of COVID-19 ELISA IgG antibody test is really unknown. Again, I think people will start asking you a lot about it. And with that said, I think I already talked for too long. We still have at least 5 minutes and I'll be happy to answer any questions.
I do see that there are a couple of questions here in the chat box. I don't know
Okay, let me just, oh, sorry, you're all seeing my screen. Let me open my chat box.
Yeah, I had asked, well, Mafe had asked something first with the proning question. Was dementia used as an exclusion criteria? Also, hi, Mafe.
Okay, here you go. Sorry, I found it. Okay, was dementia used as a inclusion criteria for proning too? Yes, you know, it was based on they are usually not alert oriented ×3 and able to follow commands. And it's because really those patients need to self-position. Unfortunately, we don't have enough nursing staff, and even, you know, just kind of self-protection as well. They can go to patient's room every 2 hours just to self-position and medication. So with most of my geriatric patients, actually was really hard to do proning. And I hope that answered your question. The next question, are there any good outcome studies whether therapeutic anticoagulation works to prevent clots in this patient? So I haven't found a study that says therapeutic anticoagulation works or does not work, but there's a couple of studies that have shown these angiogenesis and the microthrombo on the lungs. So I think that helps support the importance of anticoagulating. I would say that a lot of the patients that I lost, it was not only respiratory failure, but it was strokes or MIs. And, you know, suddenly we realized they are just throwing clots everywhere. I haven't found a study that has already compared therapeutic doses. And thank you. And any other questions? So what I was saying before I started was that one of my goals was definitely to try to encourage the new interns who just arrived in this upside down world, and it's going to be fine. You're in a great program. You have great upper levels. I know all this third year class, and you know, just ask for help if you need help. If you're struggling, if you have any fear, thoughts, just talk about it, and you're gonna find that you're all in the same boat. What follow-up do you recommend once the patient has been released back to the community? So I usually like to follow up my patients, I would say usually 7 to 10 days after hospital discharge, because one of the things that we were considering to discontinue self-quarantine was the 10 days mark. So I think seeing them between 10 to 14 days, or even 14 days. I mean, especially nowadays with the pandemic, you can even do 7 to 10 days a phone follow-up, and then if needed, a in-person visit to just, you know, check their lungs, monitor their pulse ox, at max 2 weeks follow-up, and make sure they're not anticoagulated if they were discharged in anticoagulation.
In the absence of any questions, we'll go ahead and tell Dr. Scalabrin, thank you for your time. For everybody who is attending, please complete the evaluation for Dr. Scalabrin. It's important for her to also get feedback. Thank you.
Well, thank you all. And Dr. Cruz has a presentation. I'll be happy to share with anyone that wants. And on my last page, I do have my personal email address. So feel free to email me if you have any other questions.
Thanks, Renata.
Thank you.
Renata, thanks so much. It's great to see you.
Thank you. I miss you all. Hope to see you soon.
Thank you.
Bye.